So we're going to talk about scoliosis, and as I was getting ready to give this talk, I was reminded of a family story that I think speaks to what we as providers bring home, even just by osmosis. My daughter, who's now in high school, was either 3 or 4 because she was still in preschool, and she came home from school. I came home at the end of the day, and she said, Mom, there's a new teacher at school. Her name is Mrs. Scoliosis. And I said, oh, Kate, I don't think that's her name. Her name is Mrs. Scoliosis. I know. And I thought, it turns out that she was a lovely Greek woman, Mrs. Soliotis. But only the child of an orthopedic surgeon would assume it must be scoliosis. And I thought, how much was I talking about that by the time she was 3? Anyway, alas, I must check. But so we are going to talk about idiopathic scoliosis. And here are our objectives. We'll talk about the entity of AIS, of the most frequent scoliosis that we see. We'll talk about its natural history, both about treated disease and untreated disease. There's some newer data out there that alters things a bit as we think about it. I think this will be important. We're really going to talk about sort of screening recommendations and which patients we think are appropriate for referral. And then talking about some treatment modalities, old and new. So again, scoliosis. The absolute definition of scoliosis is a lateral curvature of the spine when measured on X-ray of at least 10 degrees. And when I talk with families, I talk about the fact that we think about scoliosis being this side-to-side deviation and S-shape, but in reality, scoliosis really is this very complex three-dimensional deformity, which is why we can see what we see when we're doing clinical screening. But what else, and what I am attempting to have this show, but what I describe is that if we think about the spine moving from side to side, but three-dimensionally also rotating, then the ribs, which are attached to the spine, are going to move as well. And this may not, this is what I'll use when I talk with families, but I'll say my hands are my ribs, if you will. So my ribs are here, and they're attached to the spine. And when the spine deviates side to side, that's just the deviation. But if it rotates as well, there's going to be a change in the shape of the ribs. And so then when you bend forward, you will see a difference in the height. And classically, the ribs that are on the convex side of the curve are going to rotate up in the back. That's typically what you're seeing as your rib hump. And the ribs that are attached to the convex side of the curve are going to rotate forward. And so they will be the non-top side. And so I share with families that, what we're looking at when we're trying to do a scoliosis screen and what we are seeing here on this image is, not so much the spine, but a change in the shape of the torso or the ribs that are happening because there's a change in shape of the spine. Then we go on to talk about that there are times when there is a change in shape of the spine, potentially down in the lower spine where there are not ribs, where you can have a more meaningful curvature without a significant torso shape change. Or, corollary is you can have a change in the shape of the ribs, not necessarily due to a change in the spine, that can look more impressive. But take-home message is it is three-dimensional, it is rotational, and that changes rib shape. We are going to be focusing on adolescent idiopathic scoliosis, which is a developmental change in the spine that develops and progresses most rapidly during the most rapid times of growth, so that adolescent growth spurt between ages 10 and 15. We're not going to be talking about infantile or juvenile idiopathic scoliosis. Those really have a very different, particularly infantile, a different natural history where you might be treating with casts and things. And we're not going to be talking about congenital spinal anomalies or neuromuscular anomalies or spina bifida or spinal dystrophism, but our standard, which is by and large female, by a long. This is the classic teaching, and really, while there is new information out there, these are the big things that I talk with my families about when I'm trying to educate them about scoliosis, and they remain true. and we'll talk about them each in a little bit more detail. But small curves are common. If we look, many of us will have a curve. If there's a curve, and if it's going to get bigger, it will do so most rapidly during the most rapid times of growth. So we spend a lot of time talking about where do we think you, as a patient who might have scoliosis, is with regards to your growth, and watching things over that period of growth. There is this female predominance, certainly of larger curves, somewhere between 8 and 9 or 10 to 1. So it's females. Big curves get bigger. So we think classically that small curves stay small, big curves get bigger, but which of those small curves are going to become big curves? That's the ongoing dilemma. We don't have perfect ways, or even necessarily imperfect ways of predicting it, but we do have some information that gives us some clue to which ones might be more likely. We don't exactly know what causes it. There's clearly a familial predisposition. Anything else? And again, idiopathic scoliosis, by and large, is not painful, but we'll clarify that a little bit more as well. So again, mild scoliosis is common. If we look at all adolescents, maybe 2 or 3% of the population will have a mild curve. And when these curves are mild, they are fairly equally distributed between males and females. I classically think about scoliosis as being sort of mild curves and 1 per 100 people, meaningful curves that might require things like bracing at 1 per 1,000, and then large curves that might warrant surgery about 1 per 10,000 as sort of an estimate. And that comes from, oops, sorry, I apologize. So this information from Dr. Weinstein. But so it talks about sort of size of curvature, and the ratio of males to females, and then the prevalence within the population. But you can see that it goes from essentially equal to 10 to 1 female to male. This is an image, Embrace the Journey, #GotYourBack. This is actually taken from the website for a large support group for women with scoliosis. The name of the group is called Curvy Girls, which I get why they chose the name, but you know, like if you were to Google Curvy Girls from your Swedish-owned desktop, it may not. And if you're an adolescent female and you Google Curvy Girls, you may get stuff you don't expect. At any rate, it's a support group that was begun and done by a very talented young woman with scoliosis as well. Small curves stay small, big curves get bigger. Which ones get bigger? There really is this interplay between age, and that, if there's anything, it's age, or at least level of skeletal maturity, which speaks to those curves that are at most risk for getting bigger. So the younger you are, the more growth you have remaining, particularly if you are prior to your peak height velocity, your risk of your curve getting bigger is much higher than somebody who is done growing. That I will say, so we will talk about the fact that risk factor, being female seems to be a risk factor, 10 to 1, larger curves are in young women. Again, we will look at this paper a little bit more, but again, if you have a curve that measures 30 degrees or so, before you hit your peak height velocity, almost all of those end up progressing to a surgical range. This was a paper a bit earlier in the 80s, which was delineating skeletal maturity by the Risser sign. We'll classify that a little bit more, but that's a skeletal marker of maturity that you can see on the pelvis, that we typically can see on a scoliosis x-ray, which is why it's used. And 0 or 1 are immature folks, and if you are a skeletally immature person and you have a small curve, your likelihood if you have a small curve, 5 to 19, your likelihood of that curve progressing is small but real. If you're more mature, then that small curve likely progressing very small. Of note, you become risser 1 at about the time of menarche. Of note, though, you have your peak height velocity before menarche, and so this really doesn't differentiate anybody before that. If, however, you've got a curve between 20 and 29 degrees and you are skeletally immature, that curve has a high likelihood of progressing. And if you have a larger curve and are a bit more mature, you have a higher likelihood of it progressing, but not nearly as high as when you are younger. There is thought that thoracic curves in general are more likely to progress than S-shaped curves, thoracic and lumbar curves, which may be more troublesome down the line, are ones that are a little bit less likely to progress on their own. So we were talking about this assessment of skeletal maturity. And again, because the top of the pelvis is very frequently, not always, but very frequently visualized on the scoliosis x-ray, we watch to see the maturation. So this is a growth plate or a physis that occurs on the top of the pelvis. It initially, in the prepubertal group, it's not present and you don't see it. Around the time of menarche, it shows up on the outside part of the pelvis, and then it grows across the top of the pelvis and then fuses. And when it is fused, that is consistent with the end of spinal growth. But as you can see here, Dr. Sanders identified that, well, really a lot of the action, the peak height velocity is happening, things where we might be able to more definitively intervene is happening before this really can be visualized well on X-ray. And so he has developed a staging system utilizing the changes similar to what we look at more specifically with regards to bone age, and has delineated 8 groups that are easier to delineate. And here it's that adolescent rapid, standard stage 4, where when we can start to see those changes, that's where the most rapid growth is going to happen. Folks that have curves that are bigger than 20 or 25 degrees in this group have high likelihood of their curve progressing enough to get to a consideration for surgical range. And this was just what he spoke to. So if you look here, here is curve magnitude and stage, and you can see that really all of these, so from stage 4 down, the likelihood of getting to a surgical range is high. This was Dr. Weinstein, who practiced in Iowa, and it's my understanding, at least within the musculoskeletal world and the orthopedic world, that some of the most impressive natural history studies were done in Iowa. I'm not sure what it is about the folks that are there. I guess they don't move and they are willing participants. At any rate, he has had a 50-year follow-up of a cohort of 394 women with untreated adolescent idiopathic scoliosis. As you review the study, it initially started as a retrospective, so in the early 80s, they looked back at these 400 people, and then they identified who they were, and then from there forward, they have been watching them prospectively. And so we've gotten a lot of really good information about what happens in the untreated scoliosis. His study, which was revised with the 50-year follow-up in 2019, speaks again that if you have a small curve, but you have a lot of growth remaining, that the likelihood of your curve getting bigger is profound. If you are older, your risk of that curve getting bigger is less, but if the curve is large, you have still a meaningful set. This column, I think, is important because this really speaks to what happens to those curves, because we typically will say that if we can get you to being done growing with a curve that's 30 degrees or less, we think those curves are not going to change in maturity meaningfully. And that's what we see here. So 10% perhaps of curves 30 or less in the adulthood. We know that if you have a curve that's bigger than 30 degrees, even when you're done growing, those curves have some chance of getting bigger. Again, it's hard to predict. It happens much more slowly than during your rapid growth. But we can see that in those large curves, more than 40 degrees, that many of them will continue to progress. Now, an added challenge is that the definition of progress means that it has changed more than 10 degrees radiologically. So that means that it has gotten bigger. It doesn't necessarily mean that it has gotten to a surgical consideration range. It doesn't necessarily mean anything specifically with regards to function. But curve progression is certainly something that we are thoughtful about because it may well have issues with regards to function. But we'll continue. So we're thinking about the curves, we're thinking about which ones get bigger, but gosh, in the end, you know, what causes scoliosis anyway? We don't know. We think that, and we'll talk a little bit more about familial predisposition, you know, genetic factors, maybe there are some sites and some chromosomes. A few years back when I gave a talk about what was new and true, I spent some time talking about the Scoliosis score. I don't know if anybody knows about that, but that's a genetic test, a DNA test that theoretically was able to provide for you a score where if you had a low score, less than 50, the likelihood that your scoliosis was going to progress was very low. And if you had a high score, higher than 200, the likelihood of your scoliosis progressing was going to be very high. But in the end, everybody that we tested had a score that was like 75. And it's like, well, I could have told you that. It might get bigger, it might not, we don't know. And anyway, that DNA test has sort of kind of gone by the wayside. The reps don't come in and offer it. Families aren't asking for it. I don't do it. But there's clearly genetic stuff, and we'll talk a little bit more about that. Nutrition and overall things. There's some data about that in folks at the most risk that if we check folks with increasing progressive scoliosis, that the risk of them having a low vitamin D level seems to be present. So there may be something there. To be truthful, I've seen vitamin D being implicated in everything from fertility to all sorts of things. Whether or not there's been some early exposure to toxins and things that those might be. Hormonal dysregulation. You know, the idea that this is adolescent, idiopathic scoliosis, but you know, there's just such a change in the whole hormonal milieu as these folks are going from being children through adolescence into young adulthood. And one of those hormones that has been implicated is melatonin. I always have to remind myself that melatonin, it comes from the pineal gland. This is in fact a chicken, where in the chick there is an animal model for scoliosis where they actually remove the pineal gland, so they are melatonin deficient, and those chicks develop what looks like scoliosis, very similar to what we see in humans. The interesting thing is that we see, and again, we don't know whether this is cause or effect, but melatonin levels decrease significantly within those patients that have increased scoliosis progression. So again, maybe there is some receptor polymorphisms that may have a role, hard to say. The genetic factors, I think, are compelling and interesting. So another amazing study, I think, is the Danish Twin Registry. But they looked at several hundred sets of twins who had scoliosis. And in that setting, they had monozygotic twins who had a concordance rate of about 40%, dizygotic twins at less. What this, I think, speaks to is the fact that clearly the genetics play a part, but not everything. And so the idea that you would have identical twins who will have had, presumably, in addition to the same DNA, very much the same exposure pattern for so much of their development, and then to have the disconcordance is interesting. But so, genetic factors are there. There's been studies of family pedigrees where, as they look at that, and this came, I think, from some of that data that was generating the Scoliosis score, where they had I'm not a geneticist, so I don't know, but they had a number of families who were all Caucasian in the Midwest, and so that may not have been extrapolatable anyway. But they were trying to define which genes and DNA they thought was part of precipitating scoliosis and progressive scoliosis. But they thought that there were a couple of major genes that were likely responsible that seemed to be encoding for either extracellular matrix components or, again, this hormone receptor may have been a part. When we think about siblings, if you've got a sibling with scoliosis, there's a 7% chance that you might have scoliosis as well. And then, so that was kind of our thoughts about etiology. We don't know, family, but maybe a lot more. Again, we think that typically the classic teaching is that scoliosis, typical scoliosis, idiopathic, is not painful, which is one of the reasons that we promote screening, because folks are typically not going to be complaining of something because they have scoliosis. However, that said, and while I would still say that this is sort of the take-home message that we think that it's not painful, and if we have somebody coming in with scoliosis and pain, it behooves us to look further to identify if there is something else in addition to the scoliosis that may be causing pain. This study looked at 2,400 patients who came in with presumed adolescent idiopathic scoliosis. 560 of them, or about a quarter of them, had back pain at the time of diagnosis. So a meaningful number. Of that cohort, so about 10% of the quarter, or 48 of them were found to have an underlying condition, whether that was spondylolisthesis, a syrinx, a tethered cord, a disc herniation, a tumor. So the concern that painful scoliosis definitely means you've got something else going on, I think is less than we used to think, but it is certainly a meaningful thing. And again, if you've got somebody that you are identifying likely has a scoliosis and they have associated back pain, it's important to work them up. And so for me, that means for sure, in addition to getting that initial AP, or as we more recommend, PA view, we want to get a lateral view as well to look for the presence of maybe a spondylolysis, or being able with orthogonal views just to see the spine in more detail. So, thinking about it. So now we think about our clinical examination. Things that we're looking for. We are uneven shoulders, we can sometimes see asymmetric flank, uneven shoulder blades, the hips look off. Again, we're just not looking at our kids naked once they get to be 10 or 11. And so sometimes parents are saying, oh, we went to the beach last summer and Susie bent over to pick up her towel and oh my goodness. Or we were taking Mary off to get her prom dress and the lady kept saying that that her hem was uneven. So there are those sorts of things. And those are the things that we see. We'll comment a little bit more early on about some of the asymmetries that the patient may see and the difference of who's the beholder. But those things we're looking at. And then, of course, our Adams forward bending test. So again, we want to be able to, making sure they have their shoes off is important. I look at them standing upright first, as we have in here. So I'm looking to see shoes are off, standing height. Can I see if there is any asymmetry in the shoulder? I test to see if they have got any pain anywhere. I'm testing, can they bend forward, back, side to side? What is their mobility in addition? And then I have them bend forward, where we attempt to measure the trunk rotation or the trunk asymmetry. There are some devices that the scoliometer brand is maybe the most common. They are inclinometers, or levels is what they really are. They can be very helpful, particularly in, I think, even if you've seen somebody before, the ability to say, does that look different than it did? I just don't know. And how do you measure and how do you decide what the next piece is? So I think these can be helpful. I used to think they cost about $50. I went online and the scoliometer brand costs about $185 now, which is kind of pricey. Interestingly, there's a new brand online. I hadn't seen this one before, Baseline, and they are $30. I'm not a big app person for my phone, but there is of course an app for everything nowadays, and you can get an app to have an inclinometer on your phone, and that's about $5. And so that can be helpful. So what we are looking for is, so I think this is nice because I think you can say, I've measured it at 3 degrees, I've measured it at 5 degrees. That's great from when you're seeing them from one time to another. It's wonderful if you're in a practice where you're seeing them one time and somebody else is going to see them the next time. We do classically say that we think that it's appropriate to refer to the next step, at least x-rays, potentially orthopedics, if that number is more than 7 degrees. And that has kind of been the classic teaching for some time. One of the things that I really enjoyed about preparing for this lecture was, I was reviewing some things and came upon a paper that I hadn't seen when it came out in 2017, but I think is really important. But it was speaking about, I like the title, "The Bigger the Kid, the Bigger the Curve." But what it was, the focus of this paper is that in our kids who are heavier, which is a larger and larger, no pun intended, representation within our practices, with perhaps a third of people coming in nowadays at being overweight, that those heavier people have a body habitus which can maybe hide a number of things, and those things that we typically look for may not be as well visualized. In their study, they had 150 kids, 50 of normal weight, 50 overweight, 50 obese. And what they found that the average size of curve at presentation was larger for the obese kids. In addition to the curves being significantly larger when the obese kids presented, those kids probably, and again, not my area of expertise, but probably around that syndrome X or those things that we see, those earlier maturations that happen in our kids who are heavier, that they were also more skeletally mature. And moreover, there was a higher likelihood that that child who was overweight was going to present with a very large curve. And all of the patients who presented with curves that were in the surgical range were either overweight or obese. They classified overweight as BMI greater than 85th percentile, but what they recommended was that perhaps in that patient population that you would think about getting an x-ray at 5 degrees scoliometer or inclinometer read. Screening. There have been two, I had a friend back in New Hampshire who was part of the U.S. Prevention Services Task Force, and we butted heads frequently about the screening for hip dysplasia. And I hadn't ever really butted heads with him about screening for scoliosis, but I'm not sure that the USPST has ever said, yes, I think there's enough good data out there to screen anybody for anything. And I don't mean to be inappropriate, but everything I've read, they say, we don't have enough information to say. That said, I don't mean to be disrespectful. That said, the AAOS, POSNA, Scoliosis Research Society, AAP, believe that there are recent high-quality studies that demonstrate that we do have some non-operative interventions, bracing in specific, and we'll review that data, likely some scoliosis-specific exercises that we think have the potential to impact the natural history of scoliosis, and because of that, we think screening makes sense. And our best recommendations regarding what screening would be that females should be screened twice at age 10 and age 12, and males should be screened once at age 13 or 14. Now again, not every 10-year-old girl is the same, the early bloomers, late bloomers kind of thing, but I think this should try to capture many of those cases. So that's our best. Okay, so we think that we should, I imagine, I look whenever a kiddo comes to my office, whether it's for a fracture or whatever, I'm kind of looking at all of them and I'm checking their backs. But so we do think that we should look. We should screen clinically. If there is a inclinometer reading of more than 7 in a typically weighted child, or more than 5 in a heavy-set child, we think we should at least get some x-rays. The classic that we would recommend is getting a PA, anterolateral scoliosis. Back in the day, we would get an AP view, and the transition, this was 50 or 60 years ago, was made to take the X-ray from posterior to anterior, which decreases the radiation exposure to breast tissue and thyroid tissue and gonads by 60%. So PA is important when we can. And a lateral view, again, to make sure that normal alignment on the sagittal view is there and that we're not seeing any other associated findings. I will comment that there is another X-ray methodology called EOS, which I think is a long German name. I apologize, I don't know all of it. But it is a low-dose radiation program. And when we do not have one here. They do have the luxury of having one of them over at just the Laurel First Cancer Children. But it is 20, at least 50% less of standard conventional X-rays, and maybe as low as 20%, depending upon what you're comparing it to, whether that's conventionally obtained X-rays versus digital X-rays. And in this population where you may be getting a number of X-rays over the growth of that shadow, I think that's something to be considered. And there definitely are some families that are understandably somewhat X-ray phobic. So I have added that to my discussion with families, that I talk about that as an option. And some feel strongly enough about it that they will go elsewhere to get the X-rays. I think that is. This is actually this is a conventionally obtained X-ray. This is an EOS X-ray, and I feel like the quality is very good. When I talk with the folks at Children's in Radiology, they do mandate that the child has at least one set of conventionally obtained X-rays to make sure that they are seeing in the best detail, to make sure that there's not any subtle findings, and then subsequent X-rays can be done with EOS so that you can look, again, mostly at alignment. When we've obtained X-rays, what X-ray findings should warrant referral on? Well, I mean, yes, for sure, if you've got a curve that's 15 or 20 degrees in folks that are less than 12, we should for sure see them. A curve that is 30 degrees or more at any age, we should certainly see them. We are more than happy to see any kiddo that has a curve of any variety that you want to send. I think that, parents looking at X-rays that have meaningful curves and patients looking at X-rays that have meaningful curves and even sometimes mild curves can be startling to the parents, and sometimes they just need a way to wrap their head around it, and more information is often helpful. I think whether it's Hunchback of Notre Dame, I think there are things out there that can make the idea of a curving spine a scary or less process. Okay, so we are going to screen, we are going to do some X-rays, but what does it mean to have scoliosis? The early data that was coming out of these studies, Malcolmson's study in '68, and as late as the Stunning study in '86, really painted a pretty grim picture for scoliosis, and many of our treatment algorithms were based on what we thought was the natural history of scoliosis. And they had what they thought was a 2 times mortality rate compared to others, and that many of these patients were going to die ultimately of cardiopulmonary disease. The challenge about these studies is they were not adolescent idiopathic scoliosis alone. There were many early onset scoliosis, which does have a very different natural history impacting chest wall development, and there was a not insignificant number of neurologic and other entities. And so this is not quite what we think is going on now. There have been some newer studies, again, Dr. Weinstein and his work out of Iowa has really, the most recent data would say that the mortality rate for patients with AIS is equal to the general population. So we don't think that it has altered mortality to speak of. When we're thinking about natural history, we do kind of break it down into these groups: mortality, our cardiopulmonary function, back pain, curve progression, and quality of life. Some of which are more easy to measure and some of which are harder. But so we think mortality is equal to the general population. What about cardiopulmonary function? Well, we do know that as curves get larger, the lung volume is changed, and it decreases lung volume and the chest wall compliance as well. But that has to be taken into account as we compare folks that as we all get older, we all have a little bit less chest wall compliance. But out of Weinstein's paper in 2003, they looked at patients with curves 50 degrees or more, and they did have some reduced vital capacity and some more shortness of breath compared to controls, but they did not think that it had any apparent increase in respiratory disability. They thought these patients functioned pretty well. They thought that cardiopulmonary risk was really much more an issue when curves were very large, 100 degrees. But again, that was Dr. Ponsetti, who was also from Iowa. His work starting in the 1950s, and again, it's hard to know from this paper how many of those were truly just adolescent idiopathics. But classic, we now think that severe cardiopulmonary compromise is very, very rare in ALS. Back pain. Back pain has also been thought to be quite prevalent, maybe 40 to 90%, and maybe variable severity in those earlier studies. Our Weinstein study was quite nice. They looked at that group of 400 people with ongoing adolescent idiopathic scoliosis that was untreated, and they compared them to a similarly sized group of patients that did not have scoliosis or known back problems, and they found that scoliosis patients did have more, perhaps twice as much back pain, but it was pain that was similar in frequency and intensity and duration when compared to the controls, and that they didn't seem to have any specific radiographic arthritis that would correlate with the back pain. So we think that people with scoliosis do likely have more back pain, but we don't think that they have any more meaningful disability from their back pain compared to the general public. Curve progression. Curve progression is one that's a little bit harder, and it's real. We know, again, that it is much more likely to occur based on those of lower, those folks with more remaining skeletal growth, as we measure by Monarchical status, Risser sign, or Sanders age. Again, kind of take-home messages that curves less than 30 degrees at maturity don't seem to change any meaningful amount. If you've got a curve that is more than 50 degrees in the thoracic spine, that's likely to continue to progress in your adulthood slowly, about 1 degree per year. And if you've got curves 40 degrees or more in the lumbar spine, those too are likely to progress slowly, about 1 degree a year. And how a curve that's progressing impacts a patient is going to be different depending upon who that patient is and how they feel about it. This data is a little bit harder to know, but there were studies trying to get at quality of life and how the patient feels about their curvature. Several of the studies looking at it looked at marriage rate, which I guess, but marriage rate seemed equivalent for those with scoliosis and those without scoliosis. Interesting reproduction. So pregnancy did not seem to increase. You weren't more likely to have your curve progress because of a pregnancy, and it didn't seem like if there were documented specific difficulties having children in the setting of having scoliosis. Scoliosis patients were equivalent to controls in their depression index. It did seem that older patients with untreated scoliosis were much less satisfied than controls with regards to their body image, and maybe a third of them felt that their curve restricted them in some way, whether that was physical issues or what they could wear or just how they felt. And the Ascani paper said some felt that they were less healthy and impacted their social activities with real psychological disturbances, which was a strong quote. From the Weinstein paper, there was also a quote that said that many of the folks 50 years in, now these people in their 60s, saying that they had happy and good lives, but that they might have wanted to have had an opportunity to consider another option or treatment. So in the end, as we look at things, we think that mortality, scoliosis doesn't seem to increase your risk of mortality. Cardiopulmonary function, there doesn't seem to be a significantly increased risk in respiratory disability. You are likely to have more two times more likely to have back pain, but it's likely to be considered mild. Your curve may continue to progress about a degree a year. And quality of life, cosmetic is a hard way to put it, but just the, how do you feel about what how your body is and how it looks and how it functions. When we're thinking about treatment, kind of the classic is for curves that are less than 30 degrees or so, we continue to observe. When curves get to be about 30 degrees and upwards of 45, we will consider bracing. And in curves typically 50 degrees or more in somebody who is still growing, or 60 degrees or more in somebody who's skeletally mature, we will think about surgical stabilization. And there's a little bit, we might think about bracing somebody who's got a 25-degree curve if they are really young and they've got a lot of growth ahead of them, and or somebody that we've seen documented progression. And surgery might be considered at something like 40 degrees if it's a significant lumbar curve. Bracing. These are just a number of different braces that have been around over time. The first brace that was really used meaningfully in this country was the Milwaukee brace here, which has that neck ring. The way this was initially started out as a post-op brace for mobilization after scoliosis fusion, but then the thought was that it might be helpful in preventing curves from progressing without the need for surgery. What this brace was doing was holding onto your pelvis, and then that neck ring was sort of pulling up. It was trying to stretch your spine straight. So it was trying to take your ass and stretch it straight. And Dr. Blount would have people in this for forever. So like 35-year-old women would come back to his office and they'd still be in braces. And he wasn't sure when you should stop. And anyway, we don't really use this much at all for anything to speak of. This is the gold standard currently, and this is the Boston brace. And what Boston brace does is it is attempting to push on the spine to push it into a straighter position. So if you've got a right thoracic curve, it is going to have a pad that pushes on your right ribs to push your spine straighter, and then you'll have a compensatory left lumbar curve, and it's going to try to push on the left spine to try to push you straighter within the while the brace is on. And it has been around since the 70s, and most of the best respected brace studies are about the Boston brace. People don't love to wear their braces. Compliance is just not great. And so there have been some other braces designed with the hope that while this brace, which was meant to be worn full time, can you wear your brace less and still have it be as effective? And so there is the Charleston nighttime bending brace, which instead of just pushing the spine straight, it's trying to unbend the curvature, and then so you sleep in a brace that's like this. And the thought is you would just wear that when you're lying down and sleeping, and it works fairly well. It works better in the lumbar spine than in the thoracic spine, because you can just maneuver that better. This is the Wilmington brace, which is kind of like the Boston brace, but it just pushes harder. And there's some good data for these. This is the spine core brace, and I put it up there because the pictures, these are all soft straps, and when you go on the website for this brace, it's got like a ballerina doing ballet with the brace on, and yes, it is flexible, but there's also this big plastic thing with snaps where all the straps get strapped to, and then these straps come down through your leg. The thought was that people would be more compliant with that brace, but in the end, compliance isn't great with this either. And I'm not sure that the data would support that it does very much. This is newer brace in the 3D printing world, and that this is the Rideau Chenot brace, which instead of just trying to push things side to side, this is really trying to get a three-dimensional derotation. So it's trying to take that rib prominence in the back that's up and trying to not just push it straight, but to push that forward and pull the other one back. And there's space available here to try to have the patient actively move her spine so she's feeling that, so she's pulling away from the curve. And this is a fairly new brace, but there's some compelling information about it. I liked this picture because it showed us that, again, this is the Boston brace, which is flat, and it's just pushing side to side, but you get a bit more of a sense that there's just more rotation happening here on that portion of it. So do braces work? So the short answer is yes. But what does a brace working mean? Well, we know that braces have been shown to slow or prevent the progression of spinal deformity during growth. So they really are only able to work during growth. Am I getting close? Oh, shit. Oh, sorry. I don't know if I apologize. So braces don't make the curve go away. They can only keep a curve from getting bigger if it's going to get bigger. And they don't necessarily work for everybody. The expectation would be that when you're looking at somebody in a brace, their spine will be straighter, but when you take the brace off, eventually they will go back to the curvature that they were in prior to initiating the bracing. We talk about bracing curves 30 degrees or more. You must have growth remaining, so they must be within a year of menarche and at least Risser 2 or less. We talked about Risser sign. Once you've initiated bracing, we're typically wearing braces until folks are done growing, which is they haven't had any height change in 6 months, 18 months post-menarchal, and at least Risser 4. Typically braces worn a year to 3 years. This is the most recent study that came out in 2013, which again, they had to stop the study early because they found that the brace group was doing meaningfully better than the non-brace group, but 72% of the brace group was able to prevent progression to surgical range. They also found in this study that the more you wore the brace, the better it worked, and you had more success. So if you wore it less than 6 hours a day, it wasn't any better than observation. But if you wore it at least 13 hours a day, let me say that again, of the people that had success, 90 to 93% of those people had success wearing it only 13 hours a day. So for us, that means that maybe part-time wear is really reasonable, and we can do a little bit versus telling people they have to wear it all the time. I can't do the statistics here, but they felt that the number needed to treat to show benefit was 3. So you had to brace 3 patients to see benefit in 1. So bracing is hard. Compliance is not great. It's not for everybody. It doesn't work as well for older patients. They just don't want to wear them. It doesn't work as well for males and heavier patients. We talked about that. I do want to get to scoliosis-specific physical therapy. So here, folks talk about it. Schroth is the most common methodology. It is a physical therapy regimen to strengthen the muscles of your spine and really work to address the postural or flexible component. And ideally, it might help to prevent or slow the progression of scoliosis. It takes a lot of work. Folks go and learn this for 12 or 15 sessions and then are asked to do these exercises daily. There have been some compelling studies that perhaps it may, that compared to bracing alone, that those that were doing bracing and doing the exercises, that their rates of progression were less. And that if you were more compliant with your Schroth exercises, that you were less likely to have your curve progress. But there's only 4 Schroth physical therapists in Western Washington. Insurance doesn't necessarily cover it. It requires equipment that costs a few $100s. You have to have room in your house to install it. It's not necessarily right for every kid or every family, but it is definitely compelling. Vitamin D, they did a study where placebo, low dose vitamin D, high dose vitamin D, curve progression was lowest in the high dose group. This study recommended that maybe we should be doing vitamin D and maybe in our geographic plans we should be taking it anyway. Surgery, gold standard is spinal fusion, big surgery. We think about doing it 50 or 60 degrees. We're trying to prevent the curve from getting bigger. We'd like to get the curve straighter, and we want to maintain balance, head centered over pelvis in both people. I did want to speak about this. You know, the orthopedist is looking at the back, they're looking at the x-rays. Those are the things that we measure and we know. The patient is looking at her shoulders, her breast asymmetry, her ribs, her flanks. And it can be challenging that if that's what that patient is looking at with regards to what her outcome is, outcomes after surgery may be challenging for them because there may be residual shoulder asymmetry, there may be residual breast asymmetry, there may be residual curvature on the x-ray. And so outcomes are in the eye of the beholder. But there is good long-term outcome studies that say that at 20 to 40 years post-surgery that these patients are doing pretty well. They were similar to the control group with regards to pain. They were similar to the control group with regards to mental health. They maybe had some decreased self-image and maybe some decreased functional. It was hard to know how significant that was from a clinical significance perspective. And we think that maybe things would be better as time goes on when we're using more modern constructs. There are complications, not the least of which is the one for the neurologic injury with spinal fusion, so considering that. In the future, we are looking towards things where we don't have to fuse the spine, some growth intervention techniques, whether that's spine stapling to allow the spine to grow straighter, or some tethers that go in. These are still fairly under investigation and query. This is one more important study that I think it came out in 2017 where they looked at a group of recent patients, 190 of them with curves larger than 40 degrees who decided they didn't want to go and have surgery done, and how were they doing. And they found that there was no meaningful significant differences in their questionnaire scores, short time, 8-year follow-up. And based on that, they thought that perhaps our routine recommendations for surgery maybe need to be reevaluated. And so in summary, scoliosis is common. Large curves are much less common. Screening is appropriate. Females twice at 10 and 12, males at 13 or 14. Refer with curves on a scoliometer that measure more than 7 degrees and perhaps 5 degrees in our obese patients, and curves on x-ray that measure more than 15 or 20 degrees, or anybody that we think would benefit from our further discussion. So, okay.